Hello, my name is Brittany McClellan, and I'm a third-year cardiology fellow at Henry Ford Providence Hospital in Southfield, Michigan. Today, I will be discussing a case titled Conservative Management of CRT Lead Fracture in a patient with recovered ejection fraction using fusion pacing. So cardiac resynchronization therapy, or CRTD, is indicated in patients with heart failure, reduced left ventricular ejection fraction, and conduction delay due to its morbidity and mortality benefits. ICDs also reduce sudden cardiac death in at-risk patients. CRT restores electrical synchrony to promote mechanical coordination of the heart and left ventricular reverse remodeling. Lead fracture, while uncommon, can disrupt biventricular pacing and typically requires lead revision or extraction. We present a conservative management strategy for a CRTD lead fracture in a patient with improved LVEF and challenging anatomy by using fusion pacing to maintain resynchronization. A patient, 68-year-old woman with non-ischemic cardiomyopathy, was diagnosed initially at age 52 after presenting with dyspnea, orthopnea, and edema. At that time, she had an LVEF of 35% and a wide QRS with a left bundle branch block morphology. She subsequently underwent CRTD implantation for primary prevention at that time. Over subsequent years, her LVEF gradually improved, eventually stabilizing at 45 to 50%. 14 years later, a routine EKG showed sinus rhythm with a first-degree AV block with a QRS of 146 milliseconds with a left bundle branch block morphology. This prompted device interrogation as it was a change from her prior ECGs, and her device interrogation revealed a sudden rise in right ventricular lead impedance from 540 to over 3,000, with loss of sensing and capture consistent with an RV lead fracture. Despite having the RV lead failure, she continued to remain asymptomatic, and her left ventricular ejection fraction remained unchanged. Given the chronicity of the lead and anatomical challenges, the risk of extracting this was high. After shared decision-making with the patient, conservative management was pursued. The device was reprogrammed to minimize RV output while preserving left ventricular pacing. AV delays were adjusted to 150 milliseconds paced and 120 milliseconds sensed to promote intrinsic RV conduction and enable fusion pacing. Follow-up EKG showed a QRS narrowing of 92 milliseconds using this. 1 year later, she was due for an elective generator replacement. At that time, the patient remained clinically stable with an LVEF of 45 to 50% and no arrhythmias. Her ICD was downgraded at this time to a dual chamber pacemaker given her low arrhythmic risk. This conservative approach avoided a high voltage lead extraction and preserved her narrow QRS morphology. And you can see her EKG here, showing that her QRS is narrow at 92 milliseconds using fusion pacing. So this case highlights a conservative approach to CRTD lead fracture using fusion pacing to maintain resynchronization. By optimizing AV delay to allow intrinsic RV conduction, biventricular synchrony was preserved without extraction of the lead. CRT is proven to improve reverse remodeling and survival. Fusion pacing, blending intrinsic conduction with LV pacing, has demonstrated hemodynamics in many studies. In the 2023 HRS guidelines, they endorse fusion pacing strategies depending on the patient, and in the 2025 ACC appropriate use criteria identify increasing QRS duration and LBBB as strong CRT indications, so supporting the goal of preserving synchrony in patients with previously favorable CRT response. So in conclusion, in select patients with recovered LVEF and a fractured CRTD lead that may pose a high extraction risk, fusion pacing with device reprogramming may be a safe, effective alternative. This tailored strategy can preserve the clinical benefit while minimizing the procedural risk. Thank you.